When most people hear inherited metabolic disease, they imagine the most dramatic scenario right away. A critically ill newborn, seizures, coma, an emergency NICU admission. But some of the most dangerous cases do not look dramatic at first. In fact, the ones that fool people most are often the ones that look mild. A child may seem only a little slower than expected, a little slower to learn, a little slower to respond. Maybe the child has frequent staring spells. Maybe managing behavior becomes more and more difficult. Maybe emotions become increasingly unstable. And before long, the child is given one diagnosis after another: developmental delay, learning difficulties, epilepsy, behavior problems. But are those diagnoses really the answer? Or are they only different faces of the same underlying disorder? Today, we are going to talk about an inherited metabolic disorder that is easy to overlook, yet may be treatable: mild 3-PGDH deficiency, one of the serine biosynthesis disorders. Through the real story of a brother and sister, you will see why some children are not simply slow learners, and not merely difficult to manage. What may actually be failing is the brain's most fundamental supply system. And when a single metabolic pathway goes wrong, it can connect a long list of problems that seem unrelated at first. Developmental delay, absent seizures, behavioral problems, and declining quality of life. What looks like several separate issues may in fact all lead back to the same answer. Chapter 1. Not just a little slow to learn. How did mild 3-PGDH deficiency in these two children gradually disguise itself as developmental delay, absent seizures, and behavioral and emotional problems? Some children do not look obviously ill from the moment they are born. They are not the babies who are hospitalized again and again in infancy. They are not the children whose MRI scans look immediately alarming. And they are not the ones people recognize right away as having an inherited metabolic disorder. Instead, something feels off only gradually in everyday life. They learn a little more slowly. They respond a little more slowly. At times, they seem to stare off into space. And mixed into all of that are behavior problems and emotional ups and downs. In the end, the child collects one label after another: learning difficulties, developmental delay, epilepsy, behavior problems, or even the familiar line, "That's just how this child is." But sometimes, the real problem is not simply personality, and it is not just slow development. Sometimes the problem runs deeper. The brain may be missing a critical raw material. Today's story is about the real-life case of a brother and sister. They were from the Netherlands. Their parents were healthy and not related by blood. Neither child fit the classic textbook picture of the most severe forms of serine deficiency disorders. They did not have severe microcephaly. They did not have intractable infantile spasms in infancy. And their brain MRIs did not show dramatic abnormalities. Instead, what they had was something much easier to miss: mild, late-onset 3-PGDH deficiency. And what linked them together was not epilepsy alone. It was also learning difficulties, behavior problems, and a metabolic clue that had been overlooked for years. Scene 1. He did not suddenly become sick. He had always been half a step behind. Let's start with the older brother. During pregnancy, there was already intrauterine growth restriction. At birth, his length, weight, and head circumference were all around the 3rd percentile. Not extreme, but certainly not reassuring. As a young child, his development was clearly delayed. He pulled to stand at 10 months. He said his first word at 18 months. And he did not walk until age 2. At first, a family might try to reassure themselves. Some children are just a little slower. Boys often talk later. Walking late doesn't always mean something is wrong. But after age 3, the gap became harder to ignore. It was not just one milestone that came late. His overall development seemed consistently half a step behind other children his age. Scene 2. At age 9, he started spacing out. At age 9, the boy began having absent seizures. These seizures do not look as dramatic as full-body convulsions. They look more like the child suddenly goes blank for a few seconds. The body is still there. The child is still standing or sitting in place, but awareness seems to disappear. It is as if the brain has been placed on pause for just a few seconds, and then suddenly switches back on. His EEG showed a pattern typical of absence epilepsy. Later, anti-epileptic medication brought the seizures under control for a time, but attempts to stop the medication were not successful. On the surface, this could have looked like a child who developed a little more slowly and later happened to develop epilepsy. But what made the story truly unsettling was this: it was not over yet. Scene 3. By age 16. The most obvious problem was no longer just epilepsy. By the time he was finally diagnosed, he was 16 years old. And by then, the most striking problem was no longer just the seizures. Something about his overall condition was clearly not right. The case report states it plainly. He had shown mild developmental delay since early childhood. By adolescence, formal testing showed an IQ of 49. At the same time, he also had marked hyperactive behavior. In real life, that is not something you can explain away as simply being a little mischievous. It means he had great difficulty settling down, great difficulty staying regulated. His behavior and pace seemed persistently out of sync with the people around him. Everyone else had already moved on to the next moment, while his body and attention seemed stuck in the last one. More importantly, these were not temporary problems. They continued all the way into adolescence. He attended a school designed for children with learning difficulties. That tells us these challenges were not occasional. They were long-standing, persistent, and already affecting both learning and daily life. And yet, strangely, his neurologic examination was essentially normal, and his brain MRI was also normal. That is exactly what makes mild metabolic disorders so deceptive. A child may be struggling for years, and yet the imaging still does not immediately give you the answer. Scene 4. His problems were not dramatic, which made them easier to miss. This boy did not have hallucinations. He did not have delusions. And he did not have obvious confusion or disorganized consciousness. But that does not mean he had no neuropsychiatric problems. In fact, his presentation was exactly the kind that is easiest to overlook in real life and most exhausting for families and schools. Mild intellectual disability, developmental delay, hyperactivity, and an overall pattern of dysregulated behavior and functioning. These problems do not look dramatic, and because they do not, they are often explained away with familiar phrases. He's just a little slow. He's just hard to manage. His attention is just poor. He's just more temperamental. But from the perspective of metabolic disease, these are not a handful of separate minor problems. They are more like this. The brain has been operating for years without enough of a key raw material. And as a result, cognition, behavior, attention, and electrical brain activity have all begun to drift out of balance together. Scene 5. The sister's story brought behavioral and emotional problems to the front. The brother's case was shaped more by hyperactivity, learning difficulties, and absent seizures. The sister, however, made another side of the disorder much easier to see: behavioral problems and emotional problems. In early childhood, she did not seem abnormal from the start. The pregnancy had been uneventful. The birth had also been uneventful. At birth, her head circumference, weight, and length were all normal. Her early developmental milestones were normal as well. But after age 4, developmental delay began to emerge gradually. Later, she too developed absence epilepsy, and she developed it even earlier than her brother did. Her seizures began at age 5. She was treated with anti-epileptic medication, but even so, the absent seizures continued to occur every day. And what made her case even more exhausting was not just the seizures themselves. The report specifically notes marked behavioral problems, along with mood swings and emotional disturbance. That means she was not simply a girl with epilepsy, she was also a child whose emotions, behavior, and quality of life were being steadily burdened by the disease. This is not something you can explain away as normal teenage moodiness, and it is not something you can fully account for by saying the parenting must be the problem. Scene 6. She ended up in a wheelchair, not because the MRI was terrifying, but because daily life collapsed. First later, this girl developed severe obesity. Because of pain in her feet, ankles, and knees, she eventually needed to use a wheelchair. Her doctors believed the pain was more likely caused by joint hypermobility combined with severe obesity, rather than by a clear neurologic injury. That is because her neurologic examination, electromyography, and brain MRI did not point to a definite neurologic cause. In other words, the most exhausting part of her illness was not only the absent seizures, it was also the behavior problems, the emotional instability, the limited mobility, and the loss of quality of life. Children like this are very easily split into pieces. The epilepsy goes to neurology. The emotional symptoms go to psychology or psychiatry. The weight problem goes to endocrinology or nutrition. The pain goes to orthopedics or rehabilitation medicine. But if you gather all those fragments back together, another pattern begins to appear. Maybe this is not a collection of unrelated small problems. Maybe it is one metabolic defect showing itself across multiple systems. Scene 7. The real turning point was not the MRI, but a lab result that was only slightly low. What finally began to uncover the answer in this family was not imaging. And it was not the physical exam. It was an amino acid analysis report. The brother's plasma serine was near the lower limit of normal, 63 micromoles per litre. The reference range was 70 to 174. It was not dramatically low. It was exactly the kind of result that can easily be dismissed with a phrase like, "It's probably not a big deal." But when the team went on to test cerebrospinal fluid amino acids, the picture suddenly became clear. His cerebrospinal fluid serine was only 9 micromoles per litre with a reference range of 17 to 41, clearly low. The sister's plasma serine was also low, at 56 micromoles per litre, but she refused a lumbar puncture before treatment, so no pre-treatment cerebrospinal fluid values were available. Scene 8. They looked mild, but their biochemistry did not. What surprised the researchers most about this brother and sister was this. Their symptoms looked much milder than the classic severe infantile cases, but their biochemical abnormalities were almost indistinguishable from those seen in severe infantile patients. In other words, you cannot assume that just because a child looks less severely affected, the underlying metabolic defect must also be mild. What determines how severe the disease becomes may also involve other genetic or environmental factors. Scene 9. After serine supplementation, what improved first was not just the EEG, but the whole person. The brother began oral L-serine supplementation. Within weeks, both his family and his physicians noticed a clear change. His overall condition improved, his physical well-being improved, and his behavioral problems became less severe. Soon after that, his absent seizures disappeared. After 3 years of follow-up, his EEG no longer showed epileptiform activity. His anti-epileptic medication was successfully discontinued, and both plasma and cerebrospinal fluid serine levels returned to normal. The sister's improvement was also striking. Her behavior improved, her mobility improved, her ability to walk improved, her quality of life improved, her absent seizures stopped, her anti-epileptic medication was discontinued, and follow-up EEGs returned to normal. But there is one very sobering point. Their IQ scores did not change significantly. That tells us they were not diagnosed early. The brother was diagnosed at 16. The sister was diagnosed at 15. By that stage, treatment may no longer be able to fully reverse intellectual injury that has already become established. But treatment could still do something deeply meaningful. It could stop the seizures, stabilize the EEG, improve behavior, and significantly improve quality of life. And for a family, that is not a small change. That is why the earlier these treatable metabolic disorders are recognized and treated, the better the chance of reducing irreversible neurologic injury. Once the damage has already taken hold, treatment becomes less like driving a car back to the top of the hill and more like finally hitting the brakes on a car that is already rolling downhill. Scene 10. These behavioral and emotional problems may be one of the most deceptive faces of metabolic encephalopathy. What makes this brother and sister so memorable is not only the fact that mild 3-PGDH deficiency really does exist. More importantly, their story reminds us of something essential. An inherited metabolic encephalopathy does not always begin with severe encephalopathy, obvious MRI abnormalities, or microcephaly. It can also look very different. It may appear as mild developmental delay beginning in childhood, absence epilepsy emerging in adolescence, learning difficulties, hyperactivity, behavior problems, emotional instability, and declining quality of life. These symptoms are incredibly common in real life, and precisely because they are so common, they are easily absorbed into the framework of more common diagnoses. But this case report tells us something important. When developmental delay, epilepsy, and behavioral or emotional problems appear together, there really may be a metabolic cause hiding underneath those psychiatric and behavioral symptoms. Not every child who is emotionally unstable or behaviorally unusual is dealing with just a psychological issue, and not every child who struggles in school and also has epilepsy simply has a routine neurodevelopmental disorder. Some children's brains are not truly lacking discipline, they are lacking L-serine. Closing summary. What makes this brother and sister's story so moving is not just the fact that they were finally diagnosed with an inherited metabolic disorder. It is that they were not the most classic patients, and they were not the most severe patients. They looked much more like the children we often see in real life being delayed, misunderstood, and explained away. They could go to school, they could talk, they could live a recognizable daily life. And yet, from early on, they were a little slower, a little different, a little harder to understand. Then epilepsy, behavior problems, and emotional disturbance were layered on top. Step by step, their family was pulled into fatigue, confusion, and misunderstanding. And in the end, the real answer was hiding in a single metabolic pathway. Chapter 2. What exactly is a serine deficiency disorder? When many people hear the word serine, they assume it is just an ordinary amino acid, something that sounds more like an ingredient in a supplement. But for the brain, it is far more than that. It is not simply a nutritional add-on. Serine deficiency disorders are also known as serine biosynthesis defects. They belong to the group of inherited metabolic disorders, or IEMs. More specifically, the category of amino acid metabolism disorders. In the classic form, the three main genes involved are PGDH, PSAT1, and PSPH. You can think of these three genes as three critical stations on the same production line. If any one of them breaks down, the body's own pathway for making L-serine can get blocked. And once that pathway is blocked, what suffers is not just a lab number. What really suffers are some of the brain's most basic building blocks: cell membranes, myelin, neural signaling, and brain development itself. That is why, in these disorders, the first organ system to run into trouble is usually not the liver or the kidneys. It is the nervous system. In many children, the earliest signs are things like microcephaly, seizures, developmental delay, intellectual impairment, and behavioral abnormalities. Part 1. Why does this disorder affect the brain so strongly? Because serine is extraordinarily important to the nervous system. You can think of it this way: it is not just nutrition. It is more like a raw material the brain must have in order to function. First, it is one of the materials used to build cell membranes and myelin. Brain cells do not function as bare wires. They have membranes, they have axons, they have myelin, and serine helps make those structures possible. If serine is lacking, the nervous system is operating as if it does not have enough insulating material. Brain development may suffer. Myelin formation may suffer too. That helps explain why severe patients can develop findings such as hypomyelination, brain atrophy, and thinning of the corpus callosum. Second, serine also affects how neural signals are transmitted. It serves as a precursor for other important molecules. And those molecules matter for synaptic function, learning, cognition, and seizure threshold. So when serine is low, the problem is not simply poor nutrition. It also means the regulation of neural signaling can become unstable. Third, serine is involved in some of the brain's deepest construction work. It is tied to nucleotide synthesis, methylation reactions, and antioxidant capacity. That matters especially during fetal life and early infancy, when the brain is developing rapidly. At those stages, the consequences can be even greater. Fourth, serine deficiency may also contribute to making the wrong kinds of lipids. When serine is not available, the body may sometimes substitute the wrong raw material and produce abnormal lipids that can be toxic to nerves. This is thought to play a role in peripheral nerve injury as well. So these disorders do not damage the nervous system because serine does just one job. They do damage because serine sits at the center of several major metabolic pathways that the brain depends on most. Part 2. What can these disorders look like? One of the most deceptive things about serine deficiency disorders is just how wide their clinical spectrum can be. The severe forms can be devastating as early as fetal life. The milder forms may not become obvious until childhood, adolescence, or even adulthood. The most severe cases can begin before birth. Possible features include intrauterine growth restriction, severe microcephaly, cataracts, limb abnormalities, and skin abnormalities. Some affected infants do not survive for very long after birth. More commonly, the severe infantile form presents with features like seizures, microcephaly, developmental delay, intellectual disability, abnormal muscle tone, feeding difficulties, and clear white matter abnormalities on brain imaging. But the forms that are easier to miss are often the milder and later onset cases. These children do not necessarily look critically ill at birth. They may simply seem to learn more slowly, respond more slowly, struggle with behavior, have learning difficulties, and later develop absence epilepsy. Some people are not recognized until adulthood when they gradually develop an unsteady gait, numbness, peripheral neuropathy, mild ataxia, or cognitive slowing. In other words, the same disrupted pathway does not produce exactly the same picture in every person. This is not a single fixed syndrome that always looks the same. It is a spectrum. Part 3. How is it diagnosed? What makes this disorder so easy to miss is that people often focus on just one symptom at a time. But the real diagnostic approach is not guesswork, and it is not starting with a single gene test in isolation. The key is to assemble the full picture from the history, the biochemical testing, and the genetic results. First, start with the clinical history. If a child shows several of the following clues at the same time, this disorder should be part of the differential diagnosis: a small head circumference or poor head growth, delays in both language and motor development, seizures, especially infantile spasms or difficult to control seizures, abnormal muscle tone, feeding difficulties, ichthyosis, like skin changes, poor growth, or, later in adolescence or adulthood, behavior problems, learning problems, ataxia, or peripheral neuropathy. In later onset cases, what deserves particular attention is the combination of clues that seem scattered but keep showing up together: poor academic performance, behavioral problems, absent seizures, and peripheral nerve symptoms. Second, look at the biochemical testing. The classic pattern in these disorders is low serine in plasma and cerebrospinal fluid. In some forms, glycine may also be low. There are two important cautions here. First, plasma amino acids are best measured fasting because diet can affect the results. Second, even if plasma serine is only at the low end of normal, that result should not be brushed aside. Some real patients show only a mild decrease in blood, while their cerebrospinal fluid serine is already clearly low. CSF values are often more stable and more confirmatory. Urine amino acids, on the other hand, may be less helpful. In some patients, urine testing can look close to normal. So a normal urine screen does not reliably rule this disorder out. Third, imaging can help, but normal imaging does not exclude the diagnosis. In severe infantile cases, brain MRI often shows clear abnormalities such as hypomyelination, reduced white matter, or delayed myelination, but in mild or later onset patients, brain MRI can be completely normal. So, normal imaging does not mean there is no disease. Fourth, genetic testing provides the confirmation. A definitive diagnosis usually requires finding biallelic pathogenic or likely pathogenic variants in one of the relevant genes, such as PGDH, PSAT1, or PSPH. In some centers, if the genetic results are still not entirely clear, enzyme studies or cellular functional testing may also be used to support the diagnosis. So in the end, the most important diagnostic combination is really these three things: the clinical history, amino acid biochemistry, and genetic testing. Part 4. How is it treated? What makes these disorders so important is that they are not completely untreatable. They belong to the group of neurometabolic disorders where intervention may actually help. The core treatment is early supplementation with L-serine. In some patients, glycine may also be added under medical supervision. The point here is not that this is some miracle therapy that reverses everything. The point is this: the earlier the disorder is considered, the earlier it is tested for, and the earlier the missing substrate is replaced, the better the chance the brain has to avoid going further downhill. If the diagnosis comes too late, severe intellectual impairment that is already established is often very difficult to fully reverse. But treatment may still improve many important things: better seizure control, better overall function, improved behavior, and better quality of life. For families with a known diagnosis, prenatal diagnosis and genetic counselling are also important. This is because the disorder follows an autosomal recessive inheritance pattern. That means future pregnancies may still carry a recurrence risk. Long-term management is also about more than serine supplementation alone. It may include seizure management, developmental and educational support, feeding therapy, cataract treatment, management of neuropathy, and social support. And if a patient is taking long-term oral L-serine powder, oral hygiene matters too, and regular dental follow-up is a good idea. Final takeaway: what makes serine deficiency disorders so deceptive is that they do not always look like a rare disease at the beginning. They can disguise themselves as a child who is just a little slower to develop, a little worse in school, a little more unusual in behavior, a little more prone to seizures, or a little less steady when walking. But behind those scattered-looking problems, there may actually be one single metabolic pathway that is failing. So the key is not waiting until the disorder becomes severe enough to be impossible to miss. The key is thinking of it earlier, testing for it earlier, and replacing the missing substrate as early as possible. Because in disorders like this, time really is neurons. Chapter 3. What does late-onset serine deficiency disorder look like? When people hear Inherited metabolic disease. They usually picture a critically ill newborn, seizures, coma, and a baby in the NICU. But late-onset disease does not enter the story that way. It does not always look severe at first. In fact, what is more common is something that looks almost ordinary. Things like learning more slowly, responding more slowly, slower language development, falling behind in school, difficulty thinking flexibly, and behavior that becomes harder and harder to manage. And that is exactly what makes these disorders so deceptive. They are not missed simply because they are rare. They are missed because the clues look too much like common problems. So what do mild and late onset cases usually look like? Most often, they fall into a few broad patterns: learning difficulties, mild to moderate intellectual disability, behavioral problems, and absent seizures. Some children, early on, seem to be just a little slower than expected. But once school begins, the problems gradually become clearer. They think more slowly, they learn more slowly, they fall behind, and their behavior becomes harder to manage. By adolescence, more features may begin to pile on: restlessness, impulsivity, emotional instability, social awkwardness, and growing difficulty with self-regulation. As a result, these children are easily labelled as ADHD, borderline intellectual functioning, autism spectrum disorder, normal teenage rebellion, or simply bad behaviour. But the real question is this: behind those surface labels, is the problem really just parenting? Is it only psychological? Sometimes it is neither. Sometimes the real problem is much deeper. A metabolic pathway may be failing beneath the surface. Pattern 1. Poor learning, slow development, and cognitive impairment. One common pattern in mild PGDH deficiency is gradual developmental delay that becomes more apparent during childhood. Some children may even seem fairly normal at first in infancy or early toddlerhood, but once they begin school, the gap becomes harder to ignore. They learn slowly, they remember slowly, they process slowly. Their overall mental speed seems slower than that of other children their age. These are not always children who struggle in just one subject. More often, their learning difficulties are broad. Their overall ability to learn is what falls behind. Pattern 2. Behavioral problems. Another very common feature in later onset patients is abnormal behavior. This may include hyperactivity, inability to sit still, impulsivity, difficulty managing behavior, and poor emotional regulation. In some published cases, patients were specifically described as having marked hyperactive behavior, and after L-serine supplementation began, both family members and physicians observed that behavior improved and overall functioning improved as well. That point matters a great deal because it reminds us of something important. What looks like loss of behavioral control is not always just a parenting issue. It may also be a metabolic encephalopathy showing itself through the brain's behavioral networks. Pattern 3. Epilepsy, cognitive problems, and behavioral symptoms appearing together. In some mild patients, one of the most striking clues is absence epilepsy. The child may appear to simply blank out for a few seconds. That can be easy to miss. But these seizures often do not appear alone. They often come together with poor learning, behavioral problems, and slow development. For most families, this combination is easy to split apart. The epilepsy belongs to neurology. The academic struggles belong to the school, and the behavioural problems get blamed on parenting or mental health. But for a metabolic specialist, the crucial step is the opposite. It is putting those scattered pieces back into one single picture, because they may not be separate small problems at all. They may be different traces of the same disease, showing itself from different angles. Pattern 4. A slowly progressive chronic encephalopathy in adulthood. By adulthood, this disorder may no longer look like a typical childhood developmental condition. Instead, it can begin to resemble a slowly progressive chronic encephalopathy. Common features may include numbness, an unsteady gait, ataxia, peripheral neuropathy, and cognitive slowing. In other words, once the patient is older, the first clue may no longer be a child who developed slowly. Instead, it may become reduced motor stability, worsening neurologic function, and a mind that is gradually becoming slower. Why are late onset cases so easily delayed? Because they look too much like the kinds of problems people see every day. A little worse at school. A little unusual in behaviour. A little more emotionally unstable. A little more prone to staring spells. Each issue, by itself, does not look dramatic enough to suggest a rare disease, and that is exactly what makes it dangerous. Because once those problems are divided between different specialties, the underlying truth becomes much easier to miss. But when you place those pieces back together, a different picture emerges. This does not look like a simple psychological issue. It does not look like a routine neurodevelopmental disorder either. It looks more like a metabolic pathway deep inside the body has broken down, and the brain is simply the first organ to reveal it. Which clues deserve special attention? If a child or an adolescent shows several of the following features at the same time, it is worth discussing this possibility with a physician. First, the child has been developmentally slow from early on, struggles in school, and the difficulty is not limited to one subject. Instead, the overall pace of learning seems slow. Second, behavioural problems are prominent, such as hyperactivity, impulsivity, social awkwardness, or poor emotional regulation. Third, there is epilepsy or EEG abnormalities mixed into the picture, especially absent seizures, which are easy to overlook. Fourth, routine imaging may not look dramatic, but the child's actual function is clearly declining. Fifth, in adulthood, the person later develops an unsteady gait, numbness, ataxia, or neuropathy-like symptoms, along with cognitive slowing. These combinations deserve far more attention than any one symptom on its own. Video ending. What makes inborn errors of metabolism, or IEMs, so deceptive is that they do not always introduce themselves with a textbook picture of a rare disease. More often, they begin with a string of small problems that seem unrelated: poor learning, unusual behaviour, epilepsy, unsteady walking, emotional instability. But behind those scattered problems, sometimes the real issue is one single metabolic pathway that is failing. So for some children, the problem is not simply, this is genetic, so nothing can be done. If the defect truly lies in the serine pathway, then replacing the missing substrate as early as possible may genuinely help. Seizures become better controlled, behaviour improves, and the child's overall state becomes clearer and more stable. And the earlier the diagnosis is made, and the earlier treatment begins, the better the chance of reducing irreversible injury. Because in disorders like this, time is neurons.
If you're interested in stories at the intersection of inherited metabolic disorders, IEMS, and mental health, including cases of metabolic psychosis, you can check out the full written version in the Junyi column.